Hi guys, thanks for coming. We'll just give a few more minutes for people to join and then we'll get started. Hi guys, thanks for joining. Welcome to the second lecture in this MedEd series. Yesterday focused a bit more on a surgical topic that could come up in your AKTs. So today we're going to a more medical topic. So that's going to involve having a look at arterial blood gases and fluid balances and electrolytes. So our session today is going to cover, as I said, both the ABG interpretations, as well as how you would approach a fluid balance assessment if you were to get it in an OSCE, and some revision of how to manage electrolyte imbalances questions with a few MCQ examples tucked in there that we can work through together. So these sorts of things are completely fair game for your AKT exam, and they're also just really important skills to have in general going forwards on the wards and in acute care. There is a fair bit to cover, but I'm going to try and keep it within the hour because it's such a nice day. Please do stop me or shout out or put in the chat if I've said anything that you don't understand, I'm going too slowly or too quickly, or if anything with the slides go wrong. Fab. So we're going to start by discussing arterial blood gases. So what's an ABG? You've probably seen a few of these on your wards. They give us important information based on the acid-base balance of our patients, as well as information about the electrolytes, glucose and lactate status. The issue is we don't actually see them used that much anymore on the wards, as venous blood gases are normally sufficient and they're far less invasive than arterial blood gases. A little tip is that you do need to get an arterial blood gas signed off by the end of your 6th year. So there's no rush to do it. But if you're placed on a respiratory ward anytime in the next few months and you feel confident doing an arterial blood gas, get it signed off because they are few and far between. Some of the sort of indications that call for an arterial blood gas include really acute respiratory presentations. So if you think someone's got respiratory failure, if they're in severe shock, or if we've got a severe acid-base derangement. So these tend to be seen in resus in A&E or just in respiratory wards in really unwell patients. So I won't labour how to take an ABG, as I'm sure Kate Bonsi has gone into this in the skills lab, but to summarise, it involves using local anaesthetic to numb the area and then inserting a needle into either the radial or the femoral artery to obtain a sample of arterial blood. So how we go about interpreting them, They can be quite overwhelming at first, but there's this 5-point fail-safe system which will get you through easily through exams and through consultant grilling on the wards as well. So we'll go through each of these aspects individually, starting off with the partial pressure of oxygen. Oh, we've got a chat. Fab, you are meant to be seeing new slides. Has it not come? Fine, give me 1 second. Okay, let me just reset the slides. Fine. Apologies for this, guys. Give me 1 more minute, and if not, we'll just go without any of my notes and just show you the slides. Would one of you just mind giving me a yell to say whether you can see the slides changing at the moment?
Yep.
Amazing. Thank you. Thank you for letting me know you couldn't see them. That makes a big difference. So, yeah, going back to it. Arterial blood gases, if you follow this system in exams and on the wards, you will be absolutely fine in fourth year, let alone onto F1, F2 levels. So we start by having a look at the partial pressure of the oxygen, as quite frankly, this is the piece of data that's most crucial to the survival of your patient. So we need to check if the patient's hypoxic and thus whether they're in respiratory failure. So using the normal values, which you will always be given in an exam, so don't worry about learning them. Anything less than 11 kilopascals indicates hypoxia. Something to note is also whether an individual has additional oxygen requirements, such as a nasal cannula or any of these other additional oxygen devices seen on the screen. It's important to know these because we need to be able to assess how well a person is actually ventilating their lungs. So we use the fraction of inhaled oxygen, the FiO2, to give us an idea of the input, so the amount of oxygen someone's actually receiving in the lungs, in the alveoli, which helps us to evaluate the actual output. So how much of the oxygen we're giving them into the alveoli are reaching the arterial system. Without this, you just lack the context to be able to determine if the lungs are functioning properly. So to calculate the fraction of inhaled oxygen, you use the formula which is shown on the slides. And you may be asked to do this in an AKT question, so it's just a quick formula that's worth noting. So for example, if you had somebody who was on a 2 litre per minute nasal cannula, you would times 4 by 2, and then you would add it to the 20%, which comes from the natural percentage of oxygen we find in the room air. And that would give us an estimated fraction of inhaled oxygen of about 28%. This can then be used to formally assess oxygenation using a ratio, but that's not expected of you guys or me right now. But if anyone's eager, I can send you a link on how to explain it in further detail. So we now know by looking at the partial pressure of oxygen if our patient is hypoxic. If the answer is yes, we need to start, in reality, pulling the emergency buzzer and getting the crash team. But in an AKT question, they probably then want us to figure out whether this is due to respiratory failure. So we then look at the other partial pressure, which is CO2. And this helps us to tell whether we're in type 1 or type 2 respiratory failure. If the carbon dioxide is normal, so between 4.7 or 6 kilopascals, it's type 1 respiratory failure. And that's due to poor gas exchange at the level of the alveoli. If the carbon dioxide is high, it indicates type 2 respiratory failure, and that's due to poor ventilation. So we'll go into some of the medical causes of type 1 and type 2 respiratory failure later. But it's just important to be able to distinguish between type 1 and type 2 based on the oxygen and the CO2 that you're given. So that's the tricky bit out of the way initially. The next bit is onto basic acid-base balances. So once you've assessed the oxygen status of the patient and you know they're not going to immediately keel over due to respiratory failure, we go on to assessing whether they're in acidosis or alkalosis. So a raised pH is associated with alkalosis and a low pH with acidosis. The next step on the list is to look at the carbon dioxide to see whether that acid-base balance is driven by a respiratory cause or a metabolic cause. Because carbon dioxide makes the blood acidic by breaking down into carbonic acid, a high carbon dioxide creates an acidosis, whereas a low carbon dioxide should create an alkalosis. As the impact of carbon dioxide on pH is regulated through gas exchange and ventilation at the lungs, the pH can be changed quite quickly, and it also indicates that there's a respiratory cause for acid-base balance. So if you're in acidosis or alkalosis, either way, look at the CO2. If that's able to explain in a sensible manner why the blood is acidic, then it's likely a respiratory cause. If it doesn't, we're going to have a look at the bicarb. Bicarbonate is produced by the kidneys and acts as a buffer for that acid in the blood to try and maintain a normal pH. So if this buffer is low, we're unable to neutralize the acid, and so we'd expect the pH to be low. But if we have excess bicarbonate, we expect all of the acid to be buffered and more, and therefore we have a high pH. Because that's managed by the kidneys, this indicates a metabolic cause for the acid-base balance. So in summary, check whether we're in acidosis or alkalosis, see if the CO2 explains it. If it does, that's a respiratory cause. If it doesn't, have a look at the bicarb and see if it looks like a metabolic picture. So I like to work in flowcharts. This really worked for me in 4th year. Break it down into the different steps. A way that we can also use to remember this is the word Rome. So for respiratory acid-base problems, when you're looking at the pH and the carbon dioxide, you'd expect them to be opposite. So a low pH and a high carbon dioxide, or a high pH and a low carbon dioxide. If it's a metabolic driven problem, you're going to have equal pHs, so both high or both low. So that's always a nice fail-safe to go back to in exams. Here's all of that information just explained in a table, if that's more the sort of thing that you learn from. So we presented with values. We know whether our patient's in acidosis or alkalosis, and we're able to determine whether that's metabolic or respiratory. For a lot of the AKT questions, that's you done. But there are a few catches that you do need to be aware about. So just because the pH is normal, it doesn't mean you're off the hook. It's really important to then go and look at the other values. So compensation is the body's way of just trying to fix the acid-base balance, which is occurring by altering the different buffering activities that happen in the body. So metabolic compensation occurs through the alternation of bicarbonate production by the kidneys, and this happens over a long period of time because it requires numerous physiological and biochemical processes to occur. Respiratory compensation, however, is really quick because it only relies on carbon dioxide adjustment through altered respiratory rate to either retain more CO2 or blow more off. So complete compensation occurs when the body is able to counteract whatever imbalance we've got, such that the pH returns to a normal. However, it should be clear by looking at the other values that something's off and compensation must have occurred. A tip for exams and interpreting blood gases where the values are not normal, but our pH is within the normal range, is that compensation rarely pushes the acid-base balance past the midpoint. So if you take the normal range of the pH, which is between 7.35 and 7.45, if there was an acidosis, so a low pH, which has been compensated, the compensated pH will sit between sort of 7.35, 7.36. Whereas if there was an alkalosis, which was compensated, that pH will sit closer to the 7.44, 7.43. Finally, context is so important in these AKT questions and in clinical practice, as that will already give you a really good head start on what way we're thinking this acid-base balance has gone and why it's gone that way. So it's extremely rare that you will ever be asked to interpret an ABG without some clinical hints, and they often give you more information off the bat immediately in your head as to what's going on. So anxiety attacks is a really typical AKT MCQ question, which produce a mild respiratory alkalosis because an individual will be hyperventilating in an anxiety attack, leading to more carbon dioxide being blown off, so less acid in the blood. A patient presenting to ED with decreased consciousness and a history of diabetes is likely to be having a diabetic ketoacidosis in the world of MCQs. So check whether you can see an acute or a compensated metabolic acidosis due to the ketoacidosis that's going on. Or a patient with a 30-year history of chronic obstructive pulmonary lung disease presented with a compensated respiratory acidosis 3 months ago, but is currently having an acute infection. This may mean that they can now only partially compensate despite really wacky bicarbonate levels, which has been there due to the compensation they've had to do over many, many years. So it's always good to read the vignette and think logically back to your basics. What is this process going to be doing to my acid-base status here? 2 things to be aware of, more for your clinical years then, but it could come up on an AKT question, is there are some times when normal values, especially of blood gases, is a really abnormal situation. So if you were to get a normal oxygen level in an acute asthma attack, it's a very, very bad sign. It indicates that the patient's lost the respiratory drive and is entering a life-threatening stage of asthma. So that's the time you'd be starting to pull that emergency buzzer and make sure everyone is there. If an individual is on high flow oxygen, so like we were discussing before, if they had one of those Venturi masks and they're on high flow oxygen and they're only just able to maintain their own oxygen levels at a normal level, they probably have really impaired ventilation and gas exchange going on. So again, context is everything for you guys. Take a moment to read it, go back and read it again in the vignettes. They're really useful. So we've assessed our patient. We know they're not, or they are, in acute respiratory failure based on the oxygen levels. We've then looked at the pH, the CO2 and the bicarbonate, which tells us, alongside the clinical picture, whether we're in metabolic acidosis, alkalosis, respiratory acidosis, or respiratory alkalosis. We then probably need to figure out why. So going back a little bit to talk about respiratory failure. We mentioned that type 1 respiratory failure, so a low oxygen with a normal CO2, is caused by gas exchange failure or a mismatched VQ ratio. So causes of this include pneumonia, pulmonary edema, or things like a pulmonary embolism. Whereas someone with type 2 respiratory failure, so a low oxygen with a high CO2, has some kind of ventilatory failure. So these involve things like chronic lung conditions such as COPD or asthma, or opiate overdoses. So type 1 is a failure on the level of the alveoli. Type 2 is a more global failure on the whole breathing and ventilatory systems. So if we're looking at causes and types of respiratory and metabolic alkalosis, this table's really quite useful. And they all seem to make sense logically when you think through them. So for example, if you have someone who's vomiting significantly, they're losing a lot of hydrochloric acid, which means they're really likely to be in a metabolic alkalosis, as they are losing all of their acid through a metabolic means. So that's almost everything for acid-base balances. The only other thing that it is important to know about is an anion gap. So it's a derived value which is mainly used to assess whether a metabolic acidosis is caused by unmeasured anions, so things that we don't know. Anions such as bicarbonate or chloride are easily measured on the arterial blood gas, and so we can account for them. But there's many other anions that are less commonly measured, such as albumin. And so there is a formula, which is shown on the slides, which is the total cations minus the total anions that we know on an arterial blood gas. And that allows us to determine whether we think there's a significant amount of unmeasured anions that we need to be thinking about. So when you do that calculation, you should get a value between 15 or 20. If you get a value which is significantly more than that, we're thinking there are some other anions driving this metabolic acidosis. So for example, in DKA, ketones are what's driving the acidosis. So you'd expect a large ion gap. Certain toxins such as aspirin or methanol can also cause these acid-base balances. So it's important to know when you're in a metabolic acidosis, what is causing these different, this difference. Brilliant. So to go back and summarize one more time, 5-step system will never fail you in an exam. Check the oxygen, are they in acute respiratory distress? Check the pH, find out whether it's acidotic or alkalotic, being sure to make sure if the pH is normal, we're considering compensation. We then look at the CO2. If that explains the imbalance, we're thinking respiratory. If it doesn't, we look at the bicarbonate. Does that explain the imbalance? Then we're thinking metabolic. And then link that to the clinical context to help to determine the reason for the imbalance. So that's all arterial blood gases. We've got 2 MCQs that we're going to go through now, and then we'll have a quick short break. So, example MCQ number 1. You've got a 60-year-old man with COPD presenting to the emergency department with drowsiness. His blood gas is shown there, and what you just need to do is work out the most likely cause of the acid-base disturbance. I'll give you 30 seconds, have a think. Feel free to pop A, B, C, D, or E in the chat. There is no judgment, and I promise I'm not going to make you explain it on the call. But if you want to, feel free to put in the chat which one you think it is. Okay, let's go through it. So, when we are looking at this question, we should have all identified that we've got an acidotic picture here, which is got a raised CO2, which implies that we have a respiratory acidosis, which aligns with the history that we've just had of a COPD patient. If we look at the bicarbonate, we can see it's also slightly raised, which implies the body's trying to compensate for this respiratory acidosis. Because the renal system takes time for the bicarbonate levels to change, it makes sense that this is also a chronic picture. So a tip for MCQs is try and just rule out as many options as you possibly can. Because even if you don't know between 2, a 50% chance is better than a 1 in 5. So for here, we knew quite early on, just from the pH and the carbon dioxide, that this is a respiratory acidosis. So we can whack out the bottom 3. Then determining between the acute and chronic, both the history and the slight compensatory change of the bicarbonate leads us to think it's more of a chronic picture. So number 2, again, have a read, and then we'll go through it together in about 30 seconds. Fab. So this 45-year-old woman has a history of persistent vomiting and is presenting to you for evaluation in the emergency department. You do a rapid ABG and it shows these results. Let's start from our basics. Is she hypoxic? We're not giving an oxygen, so we assume she is not in acute respiratory failure. pH, sitting on that alkalotic side, but it is still within that normal range. The issues that are clearly quite obvious is we've got some wacky carbon dioxide and bicarbonate levels. So there's likely some sort of compensation going on here. Looking at the pH, as it sits closer to that alkalotic end, we can probably infer that the original acid-base balance was in an alkalosis, which is being compensated. So that helps to rule out the bottom 3 options. We now need to figure out whether it was a metabolic cause or a respiratory cause. Given the history of vomiting, which involves significant loss of acid, it's likely that this cause from a clinical standpoint was a metabolic one. But for completeness, we can also use the mnemonic Rome that we discussed earlier, which looks at the relationship between the pH and the carbon dioxide. So if this was a respiratory alkalosis, we'd expect the pH and carbon dioxide to be opposite, so RO, whereas if it's metabolic, we expect them to be equal, ME. Here they're both on the high end, supporting the fact that this is a metabolic acidosis caused by vomiting, which has been compensated for with some hypoventilation to cause that decrease. Fine, so that's acid-base balances done. Have 1 minute, we're then going to go on to fluid balances. If you've got any questions, please let me know in the chat, message me directly, or pipe up, whatever you feel comfortable with. So we'll start again in like a minute. Okay, fluid balance. So how we're going to go about fluid balance today is we're going to have a quick note on history and how to identify a relevant patient who's likely to have a fluid imbalance. We'll discuss basic observations and how to conduct an exam, and then we'll look at some electrolyte imbalances. So the first half will primarily be focusing on an OSCE situation, whereas the third part, where we'll look at electrolytes, is much more AKT based. So a very, very rapid recap. Hypovolemia is a deficit in fluid volume. So you need to think about poor intake, fluid loss, or third space loss of fluid, so different compartments in the body. Hypervolemia, excess fluid, so excessive intake or inappropriate retention due to chronic conditions. Moving on to patient factors that may alter fluid homeostasis. So these are the sort of people you're expecting to come up in vignettes that may have an issue with their fluid homeostasis. So either very elderly or very young patients are more prone to dehydration, and elderly patients with lots of chronic conditions are more likely to be in fluid overload. If a patient's in hospital, they're probably there for a reason which alters fluid homeostasis, since it's so crucial to just general physiology as a whole. Someone with lots of comorbidities is also more likely to have issues with their fluid balance, and anyone on lots of different medications, especially diuretics. Just a note about input and output. So it's so important to have an accurate record of fluid input and output. Now, input involves not only just the amount they're drinking, but also whether they're on nil by mouth or whether they're having IV fluid therapy as well. And outputs include urine output, and if they've got a catheter, that's great. But also stools, vomiting, bleeding. So for example, a mum could have just come from a cesarean. She may have had a postpartum hemorrhage, and that's really important to know when considering the overall fluid status of your patient. So, patient examination. We're going to whiz through this because it's quite simple. And quite frankly, I'd be very surprised if they do give this to you in your fourth year OSCE, as I think there's more important things they're going to want to test you on. However, it's fair game. It very much could come up. So have a look over this now, listen to it, maybe a week before the exam, just bang out these slides so it's vaguely in your mind if they decided to go rogue and spring this on you in an exam. It's fairly self-explanatory, so don't panic if you go into the exam and see something like this. So as always, you want to start with an ABCDE assessment. And when you're assessing C, so the cardiovascular system, is when you do the main part of your fluid status exam. So this structure is a really good one to follow, not only in critical situations, but also just if you walk into an OSCE or an exam and your mind just goes blank, because it happens to all of us. If you go through all of these systems, you know you will be safe and you won't miss anything really critical to the patient at that time. And that's all you need to do for fourth year. Be safe, escalate to your seniors, and that's all you are good then. If the patient was critically unwell, when you reach C and you assess fluid status, it's probably going to be as simple as checking the capillary refill time, their mucous membranes, or their skin turgor. However, you could just be asked to conduct a full fluid exam looking at all of the systems. So we'll talk through that briefly now. So as normal, wipe. Remember to have a good general inspection around the bed. Are they on any IV fluids? Do they have a catheter? Is that catheter connected to one of the bags, which has all of the measurements on it? So then starting top to toe, go through all of the different systems and have a look out for some key signs. So starting from the head, when you're looking at the face, you want to be looking for sunken appearance of the eyes, which is associated with a decreased volume or dry mucous membranes. You then want to look at the neck and observe the JVP. So the inferior jugular vein runs between the medial end of the clavicle and the earlobe. So measure the JVP by assessing the vertical distance between the sternal angle and the top of the pulsation. And it should be less than 3 centimeters. I've never met an OSCE actor with a raised JVP. So just look confident in analysing it and you should be fine. Then move on to having a look at their hands. So you want to check their pulse here, check whether it's thready or whether it's bounding. You also need to look for signs of poor peripheral perfusion. A note on skin turgor is that in more elderly patients, it can be quite hard to determine if they've got loss of skin turgor or just some more excess skin. So take all the findings that you have in context. If you have a patient who's more elderly, looks very well, has a normal fluid balance in all other domains except for skin turgor, take that in context. Then looking at their chest, go through the normal things you're expecting. So respiratory rate, central capillary refill time, the heart sounds and the lung fields. A note on the gallop rhythm, it's something that PassMed quite likes and is not something you would ever be expected to auscultate in your fourth year exams. However, it's a good word to be able to recognise just in case they chuck it in an AKT. It describes the third heart sound occurring after the normal lub-dub heart sounds. And it's due to hypervolemia, causing elevated atrial and ventricular filling pressures. Fine. You then go on to looking at the abdomen. Make sure for this the patient's lying flat if you haven't got them lying flat already. Abdominal distension can be caused by a wide range of pathologies, but in the context of a hydration status assessment, consider ascites. And if there is ascites, assess shifting dullness. So you should all be pretty confident on how to do this, as it's a major part of your abdominal exam that they could test you on in 4th year. But here's just a recap for you guys to read in your own time if you need. Last but not least, we are going on to edema. So both sacral and ankle edema are really important to assess. See whether there's edema and check whether it's pitting or not. And it's really important that you find the level to which it rises to, because clinically, a more elderly individual who spends a lot of their day sat down in a chair, having a bit of pitting edema up to their malleolus is probably okay. Whereas a slightly fitter, younger person with pitting edema up to the mid-thigh is a very, very different clinical picture. So be really careful to make sure you report how high the pitting edema goes, even if it means you're palpating their leg all the way up to the mid-thigh. So here's a really useful summary for just some of the key findings to look out for when assessing fluid status. At the end of every OSCE, you'll be asked normally 3 typical questions. And for some reassurance, they don't help you pass or fail. Those are just helping to rank you and give you some extra marks. For fluid status exams, you're most likely to be asked, what basic observations or investigations would you like to do next? So here's a list of them. They're basic. They're your generic full blood count, U's and E's, and some further imaging. I just want to reiterate the importance of an accurate fluid balance chart. This is often not done very well, both at home and in hospitals, but they're so key in the assessment and the management of patients with fluid homeostasis issues. Fab. Right, this is the last section of the talk. It's a bit more like the first section where we're focusing on AKT biochemical questions. So, when you're given a set of lab results, you need to think about what's normal. So you'll be given reference ranges in all your exams, but you also need to think about it in the context of your patient. And I guess this is more important for when you're on the wards or doing things clinically. If you review a patient with a sodium of 133 and panic and raise it urgently to the senior before checking any previous results, you might look a little silly if it turns out their past 2 readings have been 129 and 131, and the patient is on a sodium replacement plan. So just have a look at previous results when you're on the wards, as that can be really helpful on EPR. So we're first going to consider sodium. This is probably the most common electrolyte imbalance you'll see, and it's one they like to ask in AKTs because there's quite a few different causes and you've got to work through it systematically. So first, when you're considering hyponatremia, so low sodium, we need to consider the osmolarity. Hypoosmolar hyponatremia is the most complex one, so that's where we'll start. When you've got a low sodium in this context, it's due to solute depletion or dilution. And this can occur to varying different reasons based on the fluid status of the patient. So we'll start off by thinking about patients who have a low sodium and also an overall low fluid volume. So this is often caused by fluid loss, triggering a raise in ADH, leading to more water than sodium retention and thus dilution of the sodium. There are renal and non-renal causes for this. So some of these causes of hypovolemic hyponatremia with a hypoosmolar state. You can differentiate between whether there's a renal cause or an extrarenal cause by looking at the urine sodium, because that helps to tell you whether the kidneys are able to maintain their normal sodium regulation. So if we're expecting an extrarenal cause, so we're expecting the kidneys to be functioning as normal, in a low sodium state, we'd expect the urine sodium to be low because we want the kidneys to try and reabsorb as much as possible. So when there's an extrarenal cause, we're expecting the sodium in the urine to be less than 10 millimoles per litre. If the kidneys are the cause of the low sodium, you'd expect there to be an increased loss of sodium because the kidneys aren't able to function as they need to do to reabsorb all of that sodium and maintain a normal level in the blood. So you'd expect levels higher than 20. So if you've assessed the patient, you've got a low sodium, but your patient is euvolemic, that is, they're not acutely dehydrated or fluid overloaded, then the two main causes are SIADH or psychogenic polydipsia. So psychogenic polydipsia is a really rare condition associated with severe psychiatric conditions. So a typical MCQ that points you in that direction may involve a young person with really poorly managed schizophrenia, but it's very rare. You don't get it with sort of mild to moderate things like depression or anxiety disorders. So it's one to have in the back of your mind, but not common at all. SIADH, however, is something that you do need to know about. So it's essentially just caused by inappropriate ADH secretion by the body. And there's a whole long list of causes that can cause it, but I like to remember them using the mnemonic MAD CHOP. So any major surgeries can cause a alteration in the RAS ADH axis, and that can cause disruption and SIADH. Ectopic production of ADH is really important, especially small cell lung carcinomas. Drugs or hormone deficiencies can also impact it, as well as central nervous system disorders and pulmonary disorders. So these are just a list of things to try and commit to memory, have an idea of what can cause it. This diagnostic criteria is just sort of the common sense that we've been discussing already. So they've got a low sodium and a low osmolarity. The urine has a high osmolarity because of the high sodium, and that's inappropriate. And they're euvolemic on exam. So if you've got a low sodium, low osmolarity, but the patient appears to be fluid overloaded, we need to be thinking about more chronic causes, such as heart failure, where the RAS system is activated due to the decreased cardiac output, or things like nephrotic syndrome, where the low oncotic pressure occurring due to protein loss in the urine leads to intravascular hypovolemia and RAS activation. So to summarize, if you've got a low osmolarity with low sodium, you're thinking about the fluid status. And then you want to think about each set of causes individually. So either renal or non-renal causes if you've got low fluid status. If it's euvolemic, think SIADH. It's hypervolemic, more chronic conditions. So the other two osmolar states are far easier to interpret and can fit on one slide, thankfully. If a patient has low sodium but a normal osmolarity, we want to be thinking about a lipidemia or a hyperproteinemia. This is also known as pseudo-hyponatremia. And the excess of these lipids and proteins cause an artificial lowering of the sodium value on the blood results. And that's due to the way it's processed in the lab. So there's not actually a low amount of sodium, but the concentration is lower because there's excess of these other things which interfere with the testing. And finally, a low sodium can occur in a hyperosmolar state, so where you've got lots of other solutes causing dilution of the sodium and thus a lower lab value. And these sort of things are glucose or mannitol. So low sodium, break it down into the osmolarities, the three sets of osmolarities. There are just a few things that you want to try and exclude. So thinking about pseudo-hyponatremia, as I mentioned, if your osmolarity is in range, but also consider reporting errors or drip arm contamination if the only thing you can see is a really low sodium and everything else, including the clinical picture, is normal. Think about contaminants. So thankfully, a raised sodium flowchart fits nicely on one page. So hypernatremia can be divided into three main groups based on the fluid status or the volume status. If a patient is fluid depleted, we want to assess the urinary sodium to see whether kidneys are functioning as expected. Because if we're fluid depleted and we've got excess sodium, we're going to want to try and excrete this excess sodium. If the urine sodium is low, however, this is a sign that the physiological process isn't occurring as it should, and we're either having significant extrarenal losses of water or have entered a state of shock. If the patient is hypovolemic with normal sodium, we're considering normal diuresis. So if the patient is euvolemic, your alarm bell should be going off for diabetes insipidus, which I'll discuss more in a minute. Finally, if the patient is hypervolemic, so fluid overloaded, there are main two differentials, which is salt poisoning, which is luckily very rare in clinical practice, or primary hyperaldosteronism, which there is excess kidney reabsorption, causing an excess increase in extracellular sodium. So again, management. For fourth year, you do not need to know much management at all. I can't say none because they can chuck a little bit in there, but it will never be anything significant. So here, if you know that if someone's got a deranged sodium, correct with hypotonic fluids at the same rate of the onset, and if you know that you need to replace it at the same speed that the imbalance happened, you'll be good. So just a note on diabetes insipidus. So this is caused a bit like SIADH, but the opposite end of the spectrum. So this is due to a lack of ADH production or action, so you're unable to concentrate the urine. There can be central and nephrogenic causes. So the central causes is where you're just not producing the ADH, and that can be due to brain damage, and that can even occur post-operatively if there's damage to the pituitary during the surgery, or due to pituitary infiltration, so sarcoidosis is an example. Or you can have end organ resistance, so that can be familial, so family history is really important, metabolic, drug-induced, or just due to end organ kidney damage, so polycystic kidney disease, amyloid deposits, or kidney trauma. Fine, last section of the talk today. We should be good to finish for 7. So potassium is a primarily intercellular ion, so the concentration is really tightly regulated by the sodium-potassium ATPase pump. It's also regulated on a more chronic level by kidney excretion within the distal nephron due to aldosterone. So we've got the intracellular, extracellular regulation, and the more chronic regulation through the kidneys. Something to note is that when you're in acidosis, hydrogen ions are going to be shifted into your cells to try and correct the pH of the serum. So that's going to cause potassium ions to shift out and cause a concurrent hyperkalemic state. And the opposite will happen in alkalosis. So that will cause hypokalemia. So when you're having acid-base imbalances, you do need to be really cautious of your potassium levels and how to manage them. But again, fourth year don't need to know that. So there are 3 main causes for low potassium. Reduced intake is a rare cause in practice, as it's quite hard to significantly reduce your potassium levels in an isolated manner. However, if an individual's on artificial feeds, this can result in hypokalemia if it's not managed properly. Increased output is far more common, and this can either be due to renal causes, so diuretics, GI, vomiting, diarrhea, or cutaneous sweating, but again, extremely, extremely rare. The only other thing to note is things like insulin can cause that shift intracellularly and also cause a hypokalemic serum level. Managing, again, you don't need to know much of it. Low potassium is so important in regulating the your action potentials in the heart and the myocardium. So if you take one thing away from this talk management-wise, it's you need to monitor the ECG for anyone with a sodium or a potassium imbalance. Finally, hyperkalemia. So the causes of raised potassium can be similarly broken down. Firstly, an important consideration is when you see an isolated raised potassium, and that's likely due to an error. So for things like the purple tubes, the EDKA tubes, or hemolysis during analysis, that's a purely technical cause of raised potassium. Similarly to low potassium, you can have raised potassium caused by increased intake, again, rarely seen in clinical practice. Decreased excretion, such as in chronic diseases or when you've got medication like potassium-sparing diuretics, is another cause for retained potassium. And the only other thing to mention is that due to its intracellular nature, major muscular injuries such as crush injuries can cause a massive flux into the blood, and that can cause a significant and rapid raise in potassium. So again, management I've put on there for any keen beans that want to know it, but in fourth year, this is far more than you need to know. If you can understand that ECG monitoring throughout the potassium correction is crucial, then you'll get through the AKT just fine. Fab. We've got 7 more slides to go and then we're done. And they're all multiple choice questions. So we'll go through these again for the sake of time and we'll chat through them together. So you have a 72-year-old woman presenting to the emergency department with confusion, nausea, and unsteadiness when walking. She's got a history of hypertension, depression, for which she takes amlodipine and sertraline. On examination, she's afebrile, so no fever, a normalish BP, normalish heart rate, alert but a bit disorientated to time. So we do our bloods and these results come back. Briefly have a scan over them, try and highlight what's wrong in your own head. So we should have picked up that we're in a hyponatremic state, so we've got low sodium. We've also got some low chloride, and we've got a low serum osmolarity. That's compared to the raised sodium and osmolarity that we've got in the urine sample we took. So, based on these, which of the following is the most likely cause? So you should all be jumping towards B, SIADH. So we'll chat through it. This patient is presenting with low sodium, with a low osmolarity of the serum. So that's a true hypoosmolar, hyponatremic state. The clinical signs and urine results suggest that she's euvolemic. We haven't had any signs that she has fluid overload, so any pleural effusions or significant edema noted in the question stem, or any signs like skin turgor or sunken eyes. So therefore, this is likely to be hypovolemic, hypoosmolar hyponatremia. So this is either caused by SIADH or psychogenic polydipsia. Although this lady does have depression, that's really not a severe enough psychiatric condition to normally cause psychogenic polydipsia. Also, she's on sertraline, which is a known trigger for SIADH. And together that means that psychogenic polydipsia is far less likely. So why are not the others? Addison's disease would present with a hypovolemic hyponatremia, but you'd also expect some changes in the potassium and the ureum sodium due to the amount of aldosterone that is deficient. Diuretic overuse, we've not been told that she's on diuretics. That's a nice, easy one to rule out. We mentioned psychogenic polydipsia and hyperglycemic-induced pseudo-hyponatremia. There's no mention of diabetes, hyperglycemia, or any other causes like that. And this low serum osmolarity shows that hyponatremia is not just due to dilution due to another solute. Brilliant. So that's it for today. It was a bit quick, but I wanted to get you done before 7. I'd really, really appreciate if you could scan the feedback form and fill it in. It'll take maximum 45 seconds. And what I will do is send you all of the slides with my notes on it. So if there's anything you didn't understand, you'll have access to all of that if you fill out the form. If you've had any questions or I've said anything which doesn't make sense, please feel free to unmute yourself, put something in the chat now, even ask on the feedback form, and I'll be more than happy to try and explain it to you. If not, have a lovely, lovely evening. We should get the slides out to you as soon as we can once you filled out the form. So thank you guys for coming. So I'll chat to you here, and then I will also type in the chat in case you've left. But how you can tell someone is euvolemic clinically is the best way to do it. So is there any signs of dehydration or fluid overload? And that can normally put you in the right picture. Or you can look at the urine sodium. So for the picture that we had here with this lady, the urine results support euvolemia because the high sodium and high urine osmolarity indicates that the kidneys aren't trying to reabsorb the sodium despite the low serum levels. So that would be inappropriate if the patient was either depleted in fluids or overloaded. So that the kidneys not functioning to try and correct it, to correct a fluid imbalance, implies that the individual is euvolemic. That, along with clinical signs, makes you confident in that result. I hope that makes sense, and I'll type it out in a far more eloquent fashion in a second. Thanks for the question.